want to welcome you to Moral Reasoning and Clinical Ethics with Dr. Craig Klugman. We are delighted, as folks who work with integrated ethics in the South Texas Veterans Healthcare System, to host him today to talk about clinical ethics. He's just had a plethora of writings. He works as the Stuart and Marianne Rauder Endowed Professor of Medical Humanities and the Assistant Director for Ethics Education at the Center for Medical Humanities and Ethics at the UT Health Science Center, San Antonio. He holds a doctorate in Medical Humanities from the University of Texas Medical Branch, a master's in Medical Anthropology, and master's in Bioethics from Case Western Reserve University, as well as a bachelor's in Human Biology from Stanford University. In addition, Dr. Klugman completed a 40-year Texas mediation training and has a certificate in advanced management from the University of Nevada, Reno College of Business Administration. One of the things that I saw as I reviewed his CV was that he just has a plethora of writings and presentations, well-versed in this area, so it is our delight to have him this morning. And without further ado, I present to you Dr. Klugman. Thank you.
Thank you all for having me here today and for coming on this very sunny morning. So let's get started. Like all good presentations, I don't have anything to disclose except that I don't know about all this stuff, as the cartoon says. Ethics, sometimes called schmethics. We use the term a lot. We hear the term ethics committee. We hear the term ethical reasoning, ethics consults. Well, what does the term ethics really mean? The title of today's talk is Moral Reasoning. What's morality? We don't talk about biomorality. We don't talk about having morality cases. So what is the difference between the two? And I want to take a step back because this is one of the things we do in ethics is we define our terms. And we make sure we're always on the same page when we're beginning. Well, ethics, the technical definition, is a scientific and philosophical study of how people make decisions regarding right and wrong. So notice this is not telling you what is right and wrong. It's the study of how people make choices of right and wrong. So it's examining the process. I like to call it a process of moral deliberation. Okay, and this is helping people. So the object of the person on the ethics committee or the ethics consultant is to help people through this process, to ask the questions, to find the resources, to gain perspective. That's the goal, that's the role. It is prescriptive. So the idea is that it's what ought to be, right? In the best of all possible worlds, this is how people should behave. This is the way things are going. So when we do good ethics, we come up with things like code of ethics. Notice we don't have codes of morality, we have codes of ethics. And codes of ethics are simply guidelines to behavior. How different professions or different groups believe that you should act, or how you should not act in many cases. And at the end, it's really about values. When we say that there is an ethical conflict, it means that values are in conflict. What is more important? What is being debated? Okay, and a value is simply something of importance. So when I'm talking about ethics today, I'm talking about this process of deciding, of looking at what's right and wrong, and of coming to some sort of consensus on how we should act and behave. That's really it. The morality then is what is right and wrong, okay? And this is your belief system. So belief means it's not necessarily scientifically provable. I don't have to find a quantum particle that says morality. Everybody has their own system of belief. And you may have gotten your belief from your religion, your family, your culture, hopefully not House MD, but lots of different places that you've gotten it from, and you have chosen to accept the system of morality that you follow. If you were raised, say, in a particular religious tradition, at some point you made the choice to either continue or not continue following that religious system and all the beliefs that come with it. So this is the personal. Okay, it's really hard to argue with people about their morality because it is a belief. It doesn't have to be based in fact. So when we're talking to patients and we're asking, well, what do you think is right in this situation, we're really asking for a moral judgment. You can argue ethics. In fact, I urge you to argue ethics. This is how things move along and how we make decisions. But morality, if you start questioning somebody's morality very strongly, they're going to feel attacked. So we have to be a little more careful here. But this is your personal belief. So ethics happens in groups, right? It's a discussion a committee has. It's something we study at the university. It is this group process. Morality is what you do as an individual. And you don't have to justify this to anybody. This is yours. Ethics, you do have to give reasons for it, show your rationality. And so this is the one we do by ourselves. So when I was asked to give a talk about moral reasoning and clinical ethics, I thought I needed to start here because moral reasoning is a very personal task. And it's not necessarily what somebody does when they're doing ethics. We try to find out what people's morality is because that can determine what the values are. And those value conflicts really are what an ethical dilemma becomes. So we can negotiate and discuss that territory. But we'll never go in and try and change somebody's core beliefs and values. In fact, a study I did, about 6 years ago, looked at students taking an ethics course. And they did a pre and post test. We asked them, it was a 43-question standardized quiz about how they make choices, about what their belief systems are. And what we discovered was after 16-week class, 16th semester, I don't think anybody would survive that, 16-week class, nothing changed. They still held the same beliefs, still made decisions very similarly. What did change? They had better appreciation for different viewpoints. They said, I never realized that I could believe something so differently as someone else, and we both have really good reasons to support it. So that was one. And secondly, they were better at giving reasons for their position. So they were able to separate themselves from the belief. So it wasn't, if we were saying, having a debate on a topic, they wouldn't take it as a personal attack. So those were two very, very important outcomes we got from that look. So ethics is not about changing people's minds necessarily. Right? It's about working through processes so that we can come to a consensus. So what makes something an ethical issue? As I said, ethics are conflicts over values. Very often I see in the clinic that it's about goals of treatment. Different people have different approaches, different desires for the outcome of the case. This is really what one ought to do or what one ought not to do. The case of, do I call? This happens a lot with nurses. They feel uncomfortable with a situation. They feel like something's wrong, but should I call ethics or should I not call ethics? Because if I call ethics, maybe my attending will get upset. Maybe that'll come down to the nurse manager, come down on me. Maybe I'll get scut work. So there can be barriers to people feeling that they can access ethics consultation. We're talking about conflicts over choices here. If there's no choice, no option, there's really not a conflict here. It's when we have choices. We have to ask, does an issue cause harm to another person? Is there potential for harm? It might be a physical harm, a psychological harm, or a philosophical harm, such as taking away freedom. Big question is when somebody comes in with an infectious disease, and we have to make the question whether we quarantine them. Well, that takes away a person's liberty. And that's a harm. So what kind of harm is going to take place here? Or if we make the decision, say, to remove a ventilator, there's a harm to the family who's losing a loved one. Assuming that person dies after the ventilator is removed. That's a harm. Now, so in pretty much all cases, nobody's going to be completely happy. It's just the nature of the beast. We're trying to get the least worst decision that we can. Is there a power hierarchy influencing people's choices? When I go into the clinic, I never wear my white coat. I never wear my tie. Why? Because those are symbols of power. And patients are vulnerable. Patients are scared. They have fears. They're hurting. Anybody vulnerable is vulnerable. So by taking away the accoutrements of power, I hope to get myself more on an even level with them and let them know that I'm here to represent something other than medicine. Okay? So are their voices being heard? Are their opinions being respected? One of the things that ethics services bring in is we have the tools to make sure that everybody gets heard, that every voice gets respected. This is a fun one. What if this issue appeared on the front page of your local newspaper, so here in San Antonio, the Express News, or the New York Times? Would you feel good about what was going on in the decision that was made? So some people define an ethical issue, like how you identify it, by what if other people found out about it? Or what if my child or my parent made this action? So it's sort of a reflection of others. It's not so easy when we begin the question of, well, what makes something an ethical issue? A lot of ethics committees have this struggle of, well, we don't necessarily get a lot of consults. And what is it? Are people just so totally ethical that there's no need for them? I would love to believe that. Or is it that people just aren't sure what the ethics committee for, or they're afraid to call for a consult because of repercussions? And a lot of times the studies show that it's because we're not sure how to define something as an ethical issue. I do work with rural areas, and they see a lot of things that we here in urban areas regularly see as an ethics issue, informed consents, conflicts of interest. They don't view that way because they just don't frame it as an ethics problem. So how do you do that? Well, these are sort of questions that you can ask to ask yourself, is this an ethics question? Is there power differential? Is there potential harm? What if somebody else found out about this? Is that a good or a bad thing? Is there a question of a threat to personal reputation or integrity? So this was a study that interviewed, I think it was about 100 providers, and asked them, what do you know that you have an ethical issue? And they came up with all of these choices. One of them, the most interesting one, was that if it would personally affect your reputation, your ability to get further work, to bring in patients and clients, if people found out about this choice. So that's a reason that people use for framing something as an ethical issue. Has making a decision prevented a course of action from happening? If everybody agrees, there's really no dilemma, because we all agree on the same course. Very easy and simple. The problem is when people don't agree, when we don't know what choice to make, and so we can't move forward. That stalling is another hallmark. And sometimes it's just this gut reaction that something's not right here. Leon Cass, who headed the Presidential Council on Bioethics under President Bush, wrote a paper called The Repugnance of Moral Repugnance. And his idea was, we've got something in our guts that tells us, hey, there's something's not right here. And it's not 100% accurate, but it is sort of something to listen to. If you feel that coming up, it's like you might want to ask some of the other questions and see what's really going on here. This comes up a lot with moral conscience issues, being asked to do something that you feel is not in alignment with your values or beliefs. And there's been a whole lot of controversy on the federal level as to who's got the right not to do things in this case, and it's still not settled in that area. But that's sort of a sign that there's an ethical issue here probably waiting. And you may not know exactly what it is, but that's where an ethics consultation can really help, because it's one of the things we're trained in, is sort of seeing what might be underlying what's going on here. So when you call an ethics consultation, what are you getting? Well, some people believe that it's a committee of 12 people who didn't get picked to serve on important committees. I like to think it's a very important committee. So what will happen is that it's a consultation by one or more. Usually it's a pairing or a small team. If it's really complicated, it may go to a full committee, and they will investigate in greater depth the values here. So you might call in a specialty service, maybe cardiology because you suspect a heart problem and you want to investigate it deeper. Well, if you suspect there's an ethical or moral problem, call in another service. This is what it exists for. And we're trained with tools of facilitation and communication, and I'll talk about these in a bit, and many, many tools for ethical decision making that we can employ in the situation. Family meetings, we're really good at running those, and we can kind of figure out what's going on here and how can we maybe move this case forward a little bit. Another definition is to assist interested parties in addressing ethical issues that arise in patient care. This is a little limited. It's not always patient care. It can also be organizational issues as well. Disagreements among different levels in the hierarchy, injustice built into the system. Those are sorts of things that also can come under an ethics committee purview. What are we not? We are not medical regulation. If somebody's breaking a rule, don't call ethics. Not much we can do about it. We are not risk management. We probably save people lots and lots of hassles and expensive fights in courtrooms, but we are not risk management. That's not what we do. We are not compliance. If people aren't doing what they're supposed to do, that's not ethics. Organizational issues can be ethics and it might not be ethics, so every place is different. There is a strain in the VA of ethics that is dealing with organizational stuff, and I'll talk about that in a bit. But other places, like across the street at UH, we don't deal with organizational issues. So it depends on the place. And we are not pastoral care. We usually have pastoral care representation on the committee. Pastoral care people may be ethics consultants, but it is not pastoral care. So if you're looking for spiritual guidance at the end of life, don't call ethics, call pastoral care. What we do is we provide recommendations. We can never tell you what you must do. We can't prescribe. I'm not a healthcare provider. I'm a PhD. I can give you recommendations, I can give you tools. You can ignore them. My recommendations do go in the record. Any of the ethics consultants' recommendations go in the record. But there's no legal requirement, there's no moral requirement that you must follow this. It is your patient, not ours, in the end. We always enter these into the chart. And again, we're about a process, not an answer. I'd say probably 2/3 of the ethics consults I've been involved with haven't really had an answer. It's sort of moved beyond an impasse. It's gotten people talking to each other, thinking about things. Often something happens medically to the patient that sort of makes mute what everybody was concerned about anyway. But it's not always about the answer. The processes itself is really the important thing. There are two types of ethics consultations that people tend to do. The first, and the one that you're probably aware of, is the reactive ethics consultation. And this is where somebody calls up ethics services and says, I've got a family and they don't understand what's going on and they don't talk to each other and, they want everything done and this is just going to harm the patient, whatever it might be. Or they're abusing the patient, they want to take them home, they can't provide proper care. I mean, there's lots and lots of issues. This is when we get that call, the emergency call, we need help getting through this. This is where a healthcare provider, a family member, a medical student, a resident comes to us and says, hey, there's an ethics issue here, right? So it's being identified by the house staff, by the nursing staff, to a lesser extent social workers, or by the family, which is probably the smallest group that calls us. So we're presented with this. And it's sort of playing catch up. We're acting like the ER, trying to figure out what's going on there. The other model that's part of the integrated ethics here at the VA is called proactive ethics consultation. And this is where you're trying to identify things before they happen. And it can consist of doing chart reviews, going on the wards, and just talking to people, hey, what's going on, what are the issues? And this is where the ethics committee identifies an ethical problem. So ethicists, or people who serve on the ethics committee, put the label on. Often, this is dealing with the organizational issues. there's a gap in the process. Perhaps, we've been getting a lot of calls about not end-of-life decision-making and people not knowing what patients want. And then we can go through, look at the process and be like, there's no place, we actually had this at UH, there's no place in the record to really put in that somebody has an advance directive. No wonder why nobody can find these documents. So doing that sort of investigation, sorry I keep hitting this, is really one way that we can do. So these are probably done by small teams that will go around and they will try and figure out what's going on here, where things, and it's about creating a culture of ethics, organizational change, preventing the need for the reactive ethics consult. Okay, I figure if somebody has to call us for an ethics consult, it probably means that, often it's just, that's the way it is, people are very different, but often it's just a lack of communication, it's that there's a process not in place or something not happening. And so we can track, actually the VA has this amazing system about how they can track ethics consults and see if there are trends and if there are different things that keep reoccurring, and then you can address a systemic issue to help prevent that from being such an emergency in the future. The VA likes to use a system called cases in their ethics consultations. And cases simply means clarify the type of consultation request, assemble the relevant information, synthesize the information, explain the synthesis, and support the consultation process. Okay, cases was rolled out maybe 4 or 5 years ago, and is sort of the predominant method that is being used. All ethics consultants in the VA are trained in this method. So, what does it mean to clarify the type of consultation request? Well, who's calling, right? Characterize. What is the type of request that's going on here? Who's requesting it? Who knows about this? We usually will ask, does the attending physician know? This doesn't mean that we will only accept consults through the attending physician. It's just we want to be sure that the people we're going to go talk to are aware that we're going to go talk to them. We need to establish realistic expectations. So sometimes it's like, I've had consults where it is convince the family that they need to do X. I'm like, no, we don't do that. We don't convince anybody to do anything. We can help you talk to each other. We can help you look at the values involved and help you hopefully move beyond so that you can work together. But I'm not going to be there telling the patient what to do. Okay? We're not another physician on call to help bully up on patients. We're not there necessarily to be patient advocates and bully up on the staff. We don't do that either. We try to be a neutral party, creating what I like to call a sacred space where these conversations can happen. And we set the space. And formulate the question. Somebody, if they call ethics, they sense there's something going on. But we can help them really phrase it and see what is the issue going on here. It often is not what people think it is. It often is something a little deeper. So it's being like a detective in many ways, trying to figure out what's really underneath it. So that's the clarify and see. Who's allowed to request a consult? Anybody. According to the South Texas VA system, anybody, staff, patients, family members, or other parties can request a consult. If non-staff request a consult, then a staff member should let the appropriate physician, nurse, social worker, chaplain, or patient advocate help them through the system. But really, anybody can pick up the phone, get the operator, ask for an ethics consult. That is what the regulations say. Who actually requests consults? Well, this is a little more interesting, right? 89% of residents have never requested a consult. This is pretty telling. These are people who have had ethics training in their medical school, and only 11% of them have ever called for a consult. We'll talk about the reasons for that in a bit. We actually don't have much data beyond that. There's been a number of studies that have interviewed nurses or social workers and asked, have you ever called a consult? But nobody has ever looked at the records to see who actually does consults. So there's a big opportunity to do some research here. And there's a study that came out that looked at who can make requests, like what % of people. There's been a few of those studies. So why don't people ask for consults? And this is data from house staff and nurses when they were interviewed qualitatively. Well, they feel the attending physician won't approve of it and will make life difficult, that they just don't know ethics exists. There's a lack of awareness of this service that is available to help. And negative perception of consults. We had an ethics consult 2 years ago, and it was totally not helpful. That happens a lot too. So whenever there are services that have very low numbers, you gotta wonder if they're actually providing anything helpful and what's going on there that we can work on to make better. And again, huge fear of negative repercussions. This comes up in the nursing literature a lot, that somebody will get stuck doing scut work. I'm going to have an angry doc here. I'm going to lose my job. It's a lot of fear. Why do people call for consults? Well, they have conflict that they need help resolving. This is pretty common. They have a difficult interaction that they need help with. Often this is with a family member. This can be between different disciplines within the team. This can be there's no forward movement. People feel stuck, that nobody's actually listening and going on. They need help with planning, figuring out what the care should be for this patient and where it should go. And often emotional triggers. Somebody just got your goat, and so you don't know how to deal with it because the emotions have gotten in the way. And so they call ethics for a little bit more perspective, or to help them, I'm just done. I can't talk to this family anymore. I'm finished with them. They don't get it. They don't want to get it. They don't want to get well. Those are lots of different phrases that we often hear. So when the emotions get in the way, a lot of people will call it ethics consult. One of the questions that we have to ask, right, because part of this clarify is phrasing the question, is it really an ethics issue? And what we found is that about 80% of consults are actually communication problems, not ethics problems. Communication is about the exchange of knowledge and information between two or more parties. It doesn't have to do with values. Now, we are trained in communications and can help people with that, but that's not necessarily an ethical issue. Communication is about understanding. Do patients understand providers? Do the providers understand the patients? Do the family understand the providers? Does the patient understand the family? All these different things. Is there an accurate transfer of information? Studies have shown that when healthcare providers, of whatever discipline, are talking to family members, they tend to use a lot of jargon. We use medical language. But the average person doesn't understand it. When you think about the New York Times, right, the most eloquent, highly written newspaper we have in the United States, it's actually written for an 8th grade level. Local newspapers are written on the 5th grade level. And we're using words that somebody needs to have been in school for 18 years to understand. So communication is really important. It's very hard to put ideas and concepts and terms that everybody can understand. So that alleviates a lot of issues when you sort of look at the type of language that's being used. But ethics is not about, it can deal with lack of understanding, but it's really about value disagreements, different ideas about what's important. Irreconcilability between the beliefs and values of the providers and the patient's family. That's where ethics can really get involved. This is a lot harder than this. This is sitting people down and saying, okay, you speak, okay, what do you mean by this? All right, family, you speak, what do you mean by that? Do you hear each other? What do you think? Could you repeat what the doctor's saying? Could you repeat what the family's saying? That gets communication going. Ethics is a harder piece. When we look at a consult, these are the sorts of questions that we're going to ask. Who has requested the consult? A lot of places do accept anonymous consults, but it does make it easier if we know who has done it. We will always ask if the attending physician knows, and because we have to go speak to that person. Does the team know about the request? Are you comfortable enough that, this is sort of, are there more than one is there more than one person who feels this is a question or an issue? Or is it just one person? Because we might approach things differently. Who will be notified? Who are you going to tell about this? Or are you going to expect us to do that job? Will there need to be a family meeting? If so, who will attend the meetings? We always have a process for doing these things. How much time is available? Does a decision need to be made today, tomorrow, in a week, 2 weeks? What's our timeline for making this choice here? What does the family know? Remember, communications question here. What does the family know? What does the team know? And is there any plan for follow-up? So we're always going to want to follow up on the case. I've rarely seen an ethics consult that ends up in a final decision and everybody's happy. Usually we have to follow up several days later so we can find out what happened. And so this is, so that's back to the consult. A, so back to cases, the A is assemble the relevant information. So what is needed? What are the appropriate sources of information? There are lots of listservs and journals and books and Encyclopedia of Bioethics and different places that we can go to find information. How have other people dealt with this before? What is the evidence-based literature saying? We can gather the information from these sources and we can summarize them and figure out what is the ethics question here, taking a look at it. So who does consults? 34% of people are physicians, 31% nurses, 11% social workers, 10% chaplains, 9% administrators, 4% other. I'm an other. So that would be attorneys, ethicists, administrators. The important thing to remember is if you fall into one of these categories of being a healthcare provider, when you are in the position of being an ethicist, you are not a healthcare provider. Leave the stethoscope at home or in your office. Go with a different perspective. I have seen consults where the head consultant is a physician and the physician comes in and just is another physician and gets wrapped up with the treatment choices and the test results. That doesn't help solve the issue, it just adds another medical voice. So it's really important to have that distance and step apart from your professional identity. This is just a different hat that you are wearing. When you're doing ethics consults, when you're a consultant, there is the American Society for Bioethics and Humanities that come out with a list of competencies of what people should know and the knowledge basis and the skill set they should have to be able to do this function. The first is knowledge of sources of moral guidance, theological, secular, and philosophy. So have knowledge of lots of different theories of ethics. Know different methods of resolving moral disputes, facilitation, arbitration, consensus approaches. Knowledge of relevant statutes and case law. You do not need to be an attorney, but you certainly need to know what the major statutes and regulations are regarding health care. If I'm called in for an end-of-life issue, I need to know what advanced directive laws are. If it's a public health case, I really need to know what the public health reporting requirements are, as well as what the hospital policies are. So you need to have this sort of background knowledge. You need to have knowledge of etiquette. How do you refer to people? One of the challenges that I always encounter is when I'm meeting a family, what do I call them? First name, by last name, by title, honorific. If they're from a different culture, it could vary how I'm supposed to introduce themselves. How do I get people to be civil in a room? So knowledge of how to do this. Communication and facilitation training. That's what I did in my 40-hour facilitation training. And cultural competency. So being able to help people deal with their cultural issues. Because I believe that every clinical encounter is a cultural encounter. Language being a big part of that. So synthesize the information. This is the S in cases. Do you need formal meetings? We do a lot of curbside consults, as we call them, that people stop us in the hallway and have a simple little question, or they're concerned about something which may turn into a large consult. Often we can provide you a resource or a reference or help you out right there. To do an ethical analysis, and often I spell it correctly, Josh's not here, to look at who is the appropriate decision maker. Sometimes the patient is not the person who should be making the decision. Sometimes it's the family. Sometimes it is the healthcare providers. Sometimes it's the state guardian. And then to facilitate a conversation, to figure out what are the good actions that should happen here, or could happen here, so that people know what their choices are. Mostly, what's recommended in most training is the facilitation method. And it's not the only one, but it is the one used most often. And so this is where we are creating a safe space so that everybody can explain their views, can feel like they're not being personally attacked. And it helps lead the parties towards consensus. It doesn't always reach there, maybe half the time it doesn't, but it moves people beyond the current obstacle to get where they're going. It consists of gathering data, enhancing communication, making sure everybody's heard and everybody understands, even more importantly. Identifies areas of ethical discomfort. Right? Remember that sort of gut reaction? What gives you that? Where's that coming from? Clarifies the goals of participants. It's not everybody's goal to cure the patient or to make sure that everything ends well. Sometimes it might be bringing somebody home to die, which goes against what the healthcare providers feel they can do for this patient. So how do we deal with that? We have ethical theories, policies, laws, different things that we can provide information on. And it's very non-directive. So there's mediation where you don't direct at all. And in facilitation, you try not to be directive. You try not to tell people where to go, what to think, or what to do. But you also keep them within the boundaries. You could say, well, that's a really interesting choice, but that would violate about 4 federal laws. It's sort of, keeping people at. So we set up a ring, and we kind of keep people from stepping off the edges. Mediation wouldn't do that. Mediation would allow people to go wherever they need to go for this. So it's a hybrid method where we're not going to let people do something that violates hospital policy or is illegal, but within these confines, we're certainly going to let people figure out what they need to do on their own. What are the different tools, the toolkit that we can bring as to how you make decisions on ethics? Well, it's a pretty large toolbox. It's been developed over the last 3,500 years. So the first is called deontology, which is duty-based. So what is my obligation? What are my duties? What am I required to do? Codes of ethics, honor policies, those sorts of things, the law. Right? And this is about following it very strictly. So that's one way we can approach a case, is what do the rules say we must do in this situation? The second tool we have is called natural law theory. And it's the idea of, well, whatever is part of the universe. It actually comes out of the Catholic theological tradition. And it says, whatever is right is what's natural. However God intended things to be. And so when you hear people say comments like, it's not natural to remove life support, only God can decide when somebody goes, those are natural law arguments. Very hard to argue with because there's very few people that with certainty can say how God created the universe, if you believe that God created the universe, and how we can interpret that. But it is a perspective that a lot of people bring. Divine command theory. Whatever God says goes. Because God would only tell you to do things that were good. You may not understand the reason, it may not appear good to you, but at some level, it's good. And so this is just following the dictates of God. So you may have families that say, our religion believes this, that the 10 Commandments, we must follow this. They're using a divine command perspective. Casuistry. This is used mostly in law, but a lot of people use it in their everyday practice. It's, what did I do before? When I had similar cases last time, what did I do or not do? What was the outcome? Was the outcome something that was good or something that was bad? Should I try to emulate that, or what differences do I make? So you're looking at precedents, how you dealt with this case in the past, and then what changed, what's different about it, and then using what you decided before, whether it was good or bad outcome, that becomes a guidance for making your decision here. Situationalism. This says that there's usually a right answer in every case, but it depends on the circumstances. That the context is what's important. And you have to work through that context, that situation, to figure out exactly what the right thing is. Egoism. It's about me. If I think it's right, then it's right. And I don't really care about anybody else. I have a dog that believes in the egoism very strongly. And so what's right for her is right, okay? And there are people who operate from this perspective. Feminism. So feminism is the idea that all of these, what they have in common, is that they're about one person making a decision by his or herself. Don't care, we're not supposed to care if that affects somebody else, not supposed to be influenced by anything around us. It is, I like to think of this as I'm stuck on a desert island without even a palm tree. And I'm making my choices in a vacuum. That's the idea that goes on there. Feminist perspective is, well, it depends. It's all about the relationships. It's about caring and nurturing. This is actually the basis for nursing ethics. That it matters how I feel about this person. It matters how close I am to this particular person. So what makes people feel cared for, what actually nurtures them to health, to success in life, that's what's good. That's the right thing to do. Virtue ethics. So virtue ethics is often about role modeling. It's about what is the virtuous action. So you pick a role model, somebody who you think is a virtuous person. For a lot of Christians, that might be Jesus. When I was figuring out how to be a teacher, I picked one or two of my professors who I thought were excellent teachers and role modeled my teaching after them. And so you would ask yourself, well, what would that person do? And that helps you make your choice. So you look at the virtuous person that way. Postmodernism, it doesn't matter. It's all good. Whatever, there's no right, there's no wrong. There just is. And so it doesn't really help us to make choices, but this is the perspective of, things happen. You make choices and you accept the consequences. Okay, so there's very little guilt here. But it doesn't really provide an effective tool for us. But it is a perspective that people can bring. And the last is utilitarianism. This is the basis of public health ethics, because it's not about the individual. It's the only one that's not about the individual. It's the greatest good for the greatest number. You have 12 ICU beds, you have 14 patients. Who gets the bed? Utilitarianism. Because each patient is probably deserving of that bed. Each one of these top ones would tell you that each and every one of them should have a bed. This is the one that's going to say, okay, how are we as a group going to benefit the best? This is public health. This is vaccines. This is safe food and water. This is who gets the... I dealt a lot with this when we were doing pandemic H1N1 planning earlier in the fall. Right? How do we distribute the scarce resources? So these are all philosophical tools and a few theological tools that can be brought into looking at a case. Now, choosing any one of these is going to get you to a very weird conclusion. There's an adage, a story that's told when in a philosophy class that, okay, your best friend knocks on your door and says, please let me in, I'm going to hide in your basement, Al-Qaeda is chasing me. When they knock on the door, not if, they'll knock on the door. If you tell them that I'm in the basement, they will kill me. If you lie and say I'm not in the basement, they'll just go away. And you will never be in any harm's place. So how do you decide whether to protect your friend's life or not? Well, each one of these leads you to a slightly different conclusion. So the deontologist says, well, you can never lie. Because if you allow lies, then there's no trust, and society has nothing to base on. So, of course, you have to tell Al-Qaeda your friends in the basement, because you're never allowed to lie. It's sort of absolutes. Casuistry would say, well, what did I do last time this happened? Egoism would say, well, I don't think I want the blood or to have to clean up your body parts in my basement. So, no, I'm not going to go there. Feminist ethics would go, well, I really like my best friend. I'd be very sad if they weren't here anymore. So yes, I'm going to lie to protect my friend. Right, so lying's okay here, lying's not okay here. Virtue ethics would be, well, what would Martin Luther King have done in this situation? Or some other person that you really admired or you thought were virtuous. So you'd follow them. Utilitarianism, greatest outcome for the greatest good. Well, hey, my friend is working with Doctors Without Borders, provides healthcare for a lot of underserved people. It would be really a loss. Or my friend works for Goldman Sachs. It might not be such a bad loss, right? Depending on your perspective. Okay, so none of these lead you to the right answer, but they lead you to an answer that you can then evaluate. Right? It gives you a process. So when you're stuck, you can just apply, go through this list, and be like, okay, what answer would each one of these drive me to? And some will be ridiculous and funny, and some will be very serious and worth your consideration. But none will provide the absolute correct answer on their own. The one that's used most often in ethics, which is taught most often in medical schools and nursing schools, is principlism. And these are, rather than worrying about where to start, do we take a feminist perspective, do we take a deontological perspective, it says, okay, let's forget about that. If we put a bunch of people in a room and we gave them a case, they would agree on the case. So let's figure out what it is that they're talking about. What is their elements of deliberation? And this comes up with 4: autonomy, non-maleficence, beneficence, and justice. And of course, if anybody who serves on an ethics committee thought it was protective, we see right here that there must be some mistake. I was on the ethics committee for 22 years, as you're staring at the guy with the pitchfork. There are some strange cartoonists in the world. Autonomy is the idea that a person who is competent and capacitated has the right to make their own decisions. Self-governance. But there's a few questions. So how do we use this? How do we actually apply this concept? Well, we can ask some questions. Is the patient competent and capacitated, right? If you have to be competent and capacitated, we have to ask first if you are. If you aren't, then who is? Who is making your decisions? In Texas, we have a very nice sort of hierarchy of decision makers if somebody hasn't given us their medical power of attorney. So who does make these choices? If they are competent and capacitated, can they express the choice? Can they speak? Are they, can they speak? Can they squeeze a hand, blink an eyelid? Is there a method for them to communicate to us? Do they understand? Remember we talked about communications and understanding earlier? Do they understand? It's not enough to toss a bunch of information at your patients. The standard is understanding. Do they get it? Do they know what this means? And I actually advocate quizzing your patients. Hey, you know what? I just told you 3 side effects of this drug. Would you name me? Could you just tell me 2 of them? That shows understanding. Or how would you deal with X side effect if it happened to you? Then they have to process information. It's a higher level of thinking, but it shows understanding versus just we've tossed a bunch of information at you. Are there cultural, social, family, religious issues involved here? Maybe there were 2 families. I've had this. There were actually a second family. Mom got divorced at a certain point, remarried, has a second family. The different, the younger family wants something different than the older family that's going on. Or they belong to a religious tradition, and the tradition doesn't allow them to make certain choices, but they really think that's the right choice, and how do they reconcile that? So what are the different options that are, how do the social circumstances affect where you can go? And then simply, this is about what the patient prefers. That's really what we're trying to get at here. Doesn't mean the patient's going to get their preference, but we're trying to get at what do they want. Non-maleficence is do no harm. Right? First off, do no harm. Primum non nocere. So how do we protect people? How do we look at harm? Well, are there biases that the healthcare team brings in? Nurse may have a very strong tradition and not believe that certain things are allowable. You might be in a hospital that doesn't permit certain options. In the Catholic tradition right now, removing artificial nutrition and hydration, not allowed. It's a precept that came down from the U.S. bishops. Maybe that's what the family wants. So what are the biases and beliefs that you bring in? Studies have been coming out the last week or so, ever since the Obama administration came down with their hopeful regulation about partners, long-term partners being allowed to help make decisions in the hospital, whether they be same-sex or different-sex partners. A lot of the elderly population, they don't get married because there's actually tax benefits and you get more Social Security if you're unmarried and just live together. But they don't have the rights for visitation in the hospital. So this becomes, how do we, that could be a bias that somebody holds, that this is always wrong. And we have many cases that have come out in the last couple of weeks of hospitals that did not permit legally appointed medical power of attorney into the hospital room because they felt the relationship was wrong or that it was a same-sex relationship. There's been all over the country, lots of cases have come to light in the last few weeks. So those are biases that we bring into our work that can negatively affect the patients. If there's a proposed action, a test, a treatment, or non-treatment, what are the potential bad things from that action or lack of action? Okay, so what are the negative outcomes potentially? On the other side is beneficence. And this is an obligation to provide a benefit, to do good to our patient and our patient's families. So how can you, the nurse, the doctor, the social worker, help the patient? What can we do to make them better? And it might be just make them comfortable. Sometimes the answer is not much. How does the proposed treatment, test, or action benefit the patient? If you're going to have them do a test, what do you want to get out of it? So don't order tests just to order tests. Order tests because you're going to get a specific piece of information that's going to help. The health insurances have arguments about this all the time. So really have a direct reason for this, because any action has a potential for hurting a patient. So we really need to be sure that we have a good reason for what we do. What are the likely positive outcomes? This is not to say that we do frivolous testing and things, but how is this going to benefit the patient? If the test will show, for example, I've had people come to me and say, should I get the BRCA1 test? And I said, well, or both BRCA tests. And I said, well, if it's positive, are you going to stop having mammograms? Well, no. And if it's positive, are you going to have both breasts removed? Well, no. Then what's the point? Don't have the test because it's not going to affect your behavior at all. What do you think is medically best for the patient? A lot of times with autonomy, there's a sense that it's up to the patient decides. And yes, ultimately the patient has the final decision. But the healthcare provider needs to give a recommendation. You all have much more experience, education, training than most of the patients that walk through the door. And even if you are a healthcare provider now in the role of a patient, everything you know just kind of falls out the window. Being in that vulnerable situation really changes how we approach things. So it's okay to give a recommendation. If this was my mom, I would do X. This is what I think is the right choice. And lastly is justice. This is the community perspective. Is this the right way we should be using the resources that are involved? We don't like to talk about it, but is there coverage for this? Who's paying for it? And then are there things that are beyond our control, like the law? If somebody comes in and says, I don't want you to tell anybody that I have this STI, well, guess what? The law may say you have to report that. So you can't promise patients confidentiality in every circumstance, because there are times where you are not allowed to keep it, or abuse. Somebody comes in and says, I'm going to tell you something, but I don't want you to tell anybody else. Well, if they're reporting an abuse, if they're elder or if they're a child, you are obligated to tell. So you can't keep that confidence all the time. Other policy issues, things that the hospital requires you to do or not do, and public health interests. Somebody comes in with a very infectious disease, we might have to quarantine. There might be no choices there. Explain the synthesis. Explain what's going on to the participants. Are there additional resources needed here? Make a note in the record, and then document the consultation in all consultation service records as well. And lastly, support the process. So follow up with the participants, make changes to the process if they're needed, and if there are system issues, remember that proactive piece, make sure that's going on there as well. So this is a very quick case. We don't have a lot of time, but as part of her duties on the housekeeping staff, Mrs. Jones has been called in to clean up a patient room. While working, a physician enters the room and acknowledges Mrs. Jones but does not engage in any conversation. Dr. Lopez is trying to convince the patient to undergo a risky surgery to remove a tumor that has not responded to chemo. The patient says she has already had 3 rounds of chemo and she is ready to die. Dr. Lopez asks the patient why she hates life so much. Why does she want to hurt her family? Why is she suicidal? Dr. Lopez explains that the patient is simply giving up. After about 15 minutes, Mrs. Jones leaves the room as she hears the patient say, "Fine, I'll have the chemo, just leave me alone." Concerned about what she's seen, Mrs. Jones calls the ethics hotline. So, what's going on in this case? coercion. What else?
Yeah, I look at the bias of the doctor.
Bias of the doctor. Badgering. Anybody want to step it back? Should Mrs. Jones have called ethics? Does she have that right? Okay, she has that right. How often do you think that somebody on the housekeeping staff calls ethic consults? Okay, never. I don't think there's ever been a reported case. But why not? I mean, they see things and experience things all the time. We look at these people as background. And so we say things and do things in front of them that we might not realize we're saying and doing. So they actually get a really good insight into what's going on. Do you think there's an issue in informed consent here? Okay, so let's work through the process. Autonomy. What does the patient want? Patient wants to die. She's done. She's tried everything. She's ready to go. Is the patient's voice being heard? Okay, no. All right, beneficence. How do we benefit the patient? What would provide the best benefit to the patient here?
To make an informed decision.
To make an informed decision. How do we protect the patient's ability to make that decision? I'll let her know that there are other options. There's palliative care, there's comfort care. There might be non-experimental treatments that are available. There might be palliative surgeries that would help instead of something risky and uncertain or something less painful. Maybe there's something like pain going on here, and that's driving her decision making. Or maybe she's depressed. 3 unsuccessful rounds of chemo, I'd be shocked if she didn't have a little depression going on or major depression going on. That would be a normal response. Just because she's depressed doesn't mean she lacks the ability to make her own decisions. But it is something to look at and to be addressed. Let's look at non-maleficence. So we asked about the bias. We already identified that there might be some bias in the care provider here. Are there any ways in which we might be harming her?
Quality of life issues.
So quality of life issues. Maybe we're not allowing her to really express her voice, to self-govern herself. Are we harming her, whatever time she has left, quality of life, are we making it miserable by having her, trying to pressure her into undergoing a surgery here? Why is this physician so interested in this experimental surgery? Maybe there's a study. Maybe it's paid for by a drug company. Maybe they need another paper. Maybe they genuinely believe this is the best way to go. Lots of possibilities, but we need to dig deeper and ask questions to find out about it. And are there justice issues here? Use of resources, laws, maybe hospital policy? Potentially. So do we have a different perspective after looking at this process as the sorts of questions we'd want to ask, information we need, the conversation we'd want to take place between different people here? Yeah, a little bit. Did it lead us to a solution? No. But it's not about a solution. It's about kind of moving on to the next step, making sure that people are protected, and that good decision-making, consensus building can happen. So I think that's our time, and I want to thank you all for coming this morning and listening to me talk.
Thank you.
Thank you very much.